Good day, Australia, and warm regards from Croatia. My name is Dr. Carolina Kalan, and on behalf of my group, I would like to thank to IHPA and Activity-Based Funding Conference Organizing Committee for including our research into a conference program. Before I start with the presentation on what happened in Croatian healthcare system with regards to COVID-19 pandemic, I would like to explain my connections with Australia. They are professional and private ones. Professional ones started almost 20 years ago, and I was appointed by the Croatian government to work with a team of Australian experts who came to Croatia to help us to improve pharmaceutical policy by the implementation of the World Bank Finance project. I was privileged to work with and learn from many amazing Australian colleagues, and today I would like to mention Professor Donald Hindle. Don introduced activity-based funding concept to me. He explained the structure, logic, and history of Australian DRGs, and many years after, I defended my PhD, and I based my thesis on the knowledge that I gained from Don. So my PhD focused on exploring the link between the technical aspects of RDRG introduction in the Croatian healthcare system, and then how those technical aspects of implementation impacted efficiency of Croatian hospitals. I believe that the results of the research can be used by other countries in the region, as it happens that all former Yugoslavia countries are using one version of Australian DRGs. As for private relationship with Australia, my husband is Australian. Before I start with the presentation of our results, I would like to describe Croatia to you. Croatia is a small southeastern country, and based on the latest results, Croatia has about 4 million inhabitants. Since 2013, Croatia is a member of European Union, and that's the fact that we are very proud of. Also on the web, you will find many other descriptions of Croatia, country full of life, and my favorite is Bernard Shaw quote, and who said, "Those who seek for paradise on earth, they should come and see Dubrovnik." Unfortunately, Croatian healthcare system is facing a lot of challenges these days. Those challenges are related to aging population, increased demands, growing burden of chronic diseases, introduction of medical technologies, and then despite the decades of a transition, the life expectancy at birth in Croatia is still lower than in the EU. So, life expectancy in Croatia at the birth is 78.6 years, and then in EU it's 81.3 years. Same goes to preventable and treatable mortality rates, and then unfortunately the gap will be widened further due to the impact that COVID-19 pandemics left on the Croatian healthcare system and society at all. So, what happened in 2020? I would say that because of geographical coincidence, the Croatia was hit by COVID-19 a little bit later than other countries in the region, for example, Italy, and the first COVID-19 positive case in Croatia was diagnosed on 25th of February in 2020. Government reacted swiftly. In March, government declared a state of emergency and also introduced a new governance mechanism with a centralized approach. It means that all decisions related to COVID-19 were made at the central level. Those decisions were related to reconfiguration of hospital services. So, for example, 15% of all acute beds in Croatia were designated as COVID-19 beds. Also, government introduced other measures like lockdowns and social distancing, travel restrictions, and the combination of all those measures resulted that in April, the number of patients being admitted in Croatian hospitals dropped by 51% when it compared the same period in the 3 years before. During the summer, number of COVID positive cases was not increasing. It was decreasing, and some of those restrictions were lifted, but unfortunately, the second wave of COVID again hit Croatia in September, and the number of admissions related to COVID started increasing. In addition to COVID-19 pandemic, Croatia was unfortunate by 2 earthquakes that hit Croatian capital, and the first happened in March and the second one happened in December 2020. In our research, we analyzed the total number of admissions in 2020 in Croatian hospitals and compared it with the average number of admissions in the period of 3 years before. So we found that in 2020, 21% of patients were less treated than 3 years before. I analyzed the data publicly available on the web for Ireland, for example, and found that the number of admissions in Ireland decreased by 11%. And just before starting recording these presentations, my colleague from Ukraine sent me their figures. As I was working in Ukraine on implementation of the DRG, this is just an example of Ukrainian spirit, commitment, and courage. And I would like to thank to Serhii and Professor Pari, who send me the figures. And then apparently in Ukraine, the number of admissions in 2020 dropped by 31%. Also, in our research, we analyzed the number of admissions in the 6 selected DRGs groups that we believe are representative for the patients being admitted with respiratory manifestations of COVID-19 infections. So those selected 6 DRGs, some of them are driven by procedures like A06Z, mechanical ventilation for longer than 95 hours, and some of them are driven by main diagnosis and the comorbidities like E62. So for those 6 groups, we found that number of admissions increased by 37% during the 2020 and COVID-19 pandemics. Also, we analyze mortality rate from COVID in Croatia and compared it with the countries Ireland, UK, and Australia. And unfortunately, Croatia has significantly higher COVID death per million compared to those countries that I mentioned. But here I would like to say that maybe those figures requires further studies and the research, as in Croatia, we didn't have very clear coding guidelines to be distributed to hospitals, when to code and how to code patients died from COVID or with COVID. So these days I'm helping some Croatian hospitals to optimize their coding results, and I can still see based on the discharge letter that there is a misunderstanding and or lack of understanding when we can say that the patients died with COVID or from COVID. Also, our primary healthcare services were affected by COVID-19 pandemic, but the government introduced some new tools, digital technologies, and simplified procedures. So, for example, you can see that the number of GP visits stayed approximately the same. Our patients didn't need to go to visit GPs. It was enough to give a call or organize online meeting, and then GPs were able to prescribe therapies or extended some medical certificates needed for patients to get access to secondary health care or access to some medical devices. Unfortunately, the specialist referrals dropped by 47%, and this drop also can explain the reduction in inpatient episodes of care. As I mentioned before, in 2020, we had about 21% cases less in hospitals than 3 years before. Number of prescriptions stays the same. So this is what happened in Croatia, and then it's difficult to say did Croatia responded well or not so well comparing to other countries. I'm sure that the COVID-19 pandemic and the 2020 and 2021 will be subject of numerous research in Croatia. But what Croatia can learn is that we must have policies and strategies in place that will help us to respond to emergencies like COVID-19 pandemics, but not at the expense of other equally important health care community needs.